Welcome to the next episode of the 20-Minute Clinic. And in the studio with me today, we've got Katie Mellor, clinical pharmacist, and Lydia Hulme, social prescriber, both from Spencer Street Surgery in Carlisle. My name is Robert Westgate, you're a GP with Carlisle Healthcare, and I'm your guest host this week. And in the studio as well, we've got Paul, as ever, on wires.
I'm on the wires!
But a little bit in the background because we've only got the 3 microphones. Katie, Lydia, welcome to this episode.
Thank you.
I think this morning we're going to have a bit of a CPD focus, looking at your areas of interest and what we can learn from that, what we can share with the listeners. So just tell me a bit more about your area of interest in practice. So what do you do day to day, and what sort of impact does it have clinically?
So I'm a clinical pharmacist working at Spencer Street Surgery, and my passion is helping people that have chronic pain, so supporting them through that. Part of it is to do with trying to reduce the amount of medication that they're on, because we all know that the medication doesn't really help, and if we can get them doing other activities that will help their pain, then that is what we want to help them with. But it's very difficult for people to make that shift, that mindset change. So that's why myself and Lydia and the physio as well in the surgery work quite closely together to try and help them with that.
Could I just pick up on something you said, which I absolutely get, around the issues with prescribed medication in chronic pain. The Verve said the drugs don't work, they just make it worse. But lots of people take medication for chronic pain. So what are the issues, what are the problems with using medication for chronic pain? Why is it a problem?
I feel like the most important issue is the person has tolerance to these medications, because usually they've been on it for longer than a few months, and they do feel that it works, because if they always say, if I skip a dose or if I miss a dose, then my pain comes back with a vengeance. And I try to explain that that's a bit like a withdrawal symptom from the medication, and that if we can reduce it very slowly, then you hopefully wouldn't get that reaction again. And also, we all know about the different side effects of these medications as well, and that can really impact on a person's day-to-day life, but they don't realise it until they've actually started to reduce. And I get so many comments from patients saying, oh my goodness, I can function now, I've got my life back, and it's that big an impact, but they don't realise it right at the beginning of the journey. I feel like I could talk about this for ages. So
there's something about side effects and
Yes.
people then developing a tolerance to medication that they need to continue to take to prevent those
Yes.
side effects. Are there safety issues as well? Because someone might say, I'm on this medication, it helps me to function. If I miss a dose, I feel worse, so I keep taking it.
Yes.
But are there safety issues? What are the other problems around long-term analgesic use for chronic pain?
If you're taking, say, opioids, if we're talking about opioids, if you're taking that for a long period of time, then you want to start increasing the dose, and that can become problematic, because if you're increasing the dose more and more, you then get more and more adverse effects. So we all know about the adverse effects of constipation, of dizziness. You can fall over more. So for the elderly, we want to try and reduce the chances of them falling over. There's just so much. I feel like it's not just about the medication when we're talking about chronic pain. It's about their whole lives. It's about their whole day-to-day life. And I think that's what I kind of want to get across in this podcast.
Thank you. Just before we move on from medication, is medication use for chronic pain a particular problem in North Cumbria, or is it more of a national issue, or do we see pockets of sort of increased prescribing that would be sensible to address, because we're looking at outliers in the system and maybe more risk associated with that?
It's a worldwide problem. Yes, it's not just in this area. We do have quite high prescribing of opioids, but we have made such inroads into reducing that. And it's not just about taking the medication away from these poor people, because they are struggling. It's about supporting these people to try and find different ways to help their chronic pain rather than medication. So yes, there is a problem everywhere.
And I guess just for context, there is a role for opioid analgesia.
Yes.
In different situations, so thinking about maybe acute severe pain.
Yes.
Thinking about cancer-related pain, it's end of life, etc. But the context that we're thinking of is chronic, enduring, non-cancer related pain.
Yes.
And particularly opiate and associated medication sort of overuse when there are other options that can support people to live well with their chronic condition. Is that fair?
Yeah. And the difficulty is when you've got someone who's got acute pain in front of you, you might say, right, okay, let's start you on some codeine. But that's the difficulty is then if you've not explained to that person that this is just for short term, you've got a couple of months codeine here, or you'll be on it for maybe a couple of months, and I want you to try and reduce that down to nothing. It's getting the person to understand that this is just a short-term fix.
So with an acute prescription for an acute problem, the education around how that medication's to be used, so it can be used safely in that acute episode without developing longer-term tolerance or longer-term usage and longer-term then request for ongoing medication.
And it's trying to change that mindset, I've mentioned mindset before, with the person that this isn't the quick fix. You have to try and find other ways to help with that pain. And that's, I always say, when you're trying to reduce somebody's medication and you're trying to support them, it is like a dance. You're backwards and forwards. You'll take a little bit of like 5 milligrams, reduce the morphine by 5 milligrams. And it may be that they're like that for a couple of months and they can't reduce back down. And it's supporting that person, but, we don't always have the manpower to do that. And that's why I usually say, Lydia, can you help?
So we've talked a little bit about medication, but obviously living with a chronic condition is more than medication and more than thinking about medication reduction.
Yes.
So what other supports are there for people to live well with chronic pain or to address chronic pain through what they do and how they live?
I usually just direct them to lots of different websites, so Live Well with Pain, Flipping Pain, that type of thing. But I do have quite a few patients that need a lot more support, and there's a lot more going on in their lives. And we all know that if you are feeling anxious, your pain increases. So that's when I usually say we've got this lovely social prescriber called Lydia, and she will help you and she will fix everything.
Bold.
So Lydia, can we turn to you?
Absolutely.
And are you happy just to describe some of the tools or supports that are available to people to live well with chronic pain?
Yeah, I think firstly it's really important to take the time to have the conversation with that patient about their feelings and their emotions associated with reducing that analgesia. So, for example, patients will often say to me, I've been told I have to not take this, or I'm having this taken away from me. So I think sometimes turning that script around a bit and reframing it as it's not that anyone wants to take anything away from you, but we want to see if we can manage this better, because if week on week we are still seeing you in the surgery or we're speaking to you on the phone and your pain is still really significant, actually, is there something else that we could be doing to help you? Because it sounds like the things we've tried so far haven't really worked. So maybe it's time to have another go with something else. So I always say to patients, nothing ventured, nothing gained. Why not try something new? We're really fortunate actually in Carlisle, for quite a small place with relatively challenging transport links around the city. We are quite lucky that we've got some really, really good places available. We've got ICANN Wellbeing, and they run not just the fitness and the rehabilitative and the strength and conditioning, physical conditioning side of managing chronic pain, but they also run peer support groups. They have other groups coming in. They have other specialists coming in to host groups. So there's a massive range of stuff that they can provide. And often the first step is if I can get a patient through the door of ICANN or any other VCSE organisation, or even into, in some cases, let's see the physio first before you start things. Let's see the FCP. And let's have that conversation about, are you safe to move? Because some people will think, I can't move, I'm in pain, I'm going to hurt myself more, I can't start anything new. We've got lots of walking for wellbeing groups in the city, through Ramblers, through community centres. Botcherby Community Centre's got a fantastic fitness provision. Currick House is wonderful. They've got a really comprehensive calendar of events every month that they release. But so much of people who end up really isolated with chronic pain so much of it comes down to they've been in pain, they've started medications, they feel quite lethargic, they feel quite tired, they disengage with their friends, with their family groups, with their social contacts, and that can go on for years and years. I'd say 30% of my caseload is patients who say, I used to do all of this stuff and I don't do anything now. I'm just here in my house all day, every day. Things have snowballed to the extent that they haven't got enough money because of having to quit work or feeling that they've needed to give up working. They don't have money to heat the house properly, to buy good quality groceries. They just don't. You've really got to start from the ground up sometimes with this patient cohort to look at actually what has caused this situation where they can take relatively large doses of analgesia, especially opioids and gabapentinoids, and they still are in so much pain that they just stop going out entirely. I find that a lot of the time it's a case of starting completely from scratch. I always ask, routine inquiry for every patient is, can you heat the house? Are you eating a hot meal every single day? Have you got access to a phone that you can phone people on? Because it's really common. We see a lot of patients who will say between each other, oh, they have access to a phone on a Thursday, or are there other referrals first that we need to get in place so we can scaffold them with those essentials before we start looking at the extras? And that's certainly a change I've seen in the last 5 years in this side of the role, is that actually the issues we used to see would be people felt quite lonely, but now there's such a massive number of the wider determinants of health that are stacked against people that we need to get the foundation right before we can start to really increase their social interaction. But there's a massive amount in the city for patients and for clinicians to refer to. So it's well worth getting in touch with either social prescribers or on the Joy app. There's a lot to be seen. So there's definitely things available.
There is so much out there, isn't there? But we just don't know about it. And I think a lot of patients don't know about it too. So that's why you fix them all.
And a lot of patients perhaps don't have access to the internet where they can Google it and find it out. Lots of patients don't have access to Facebook easily, and a lot of community centres put all of their information and timetables out on Facebook. And they say, well, I can't use that. And I've been in rooms with people before who've said to me, trouble is I can't read, so I'm not going to be able to. And they've seen clinicians and the job centre. I've had 3 or 4 patients over the last 2 years who've come to me and said, oh, the job centre needs this, that and the other out of me. And I've said, so what's stopping you from being able to do it? Bring it all in, let's look. Well, I can't read. And that's no one's worked that out. No one's realised that people aren't literate yet. So there's so much to be able to do. Often if you refer a patient to PHX training for perhaps a mental health first aid class, or if you refer to adult learning in Cumberland for their classes, by the time patients have got a few things in the calendar, they've got a bit of food in the fridge and they've got a couple of bits and bobs to do throughout the week. And it's not just a case of filling their week for the sake of putting social activities in a calendar. They have to matter to that patient. They have to count. We could all fill our calendars with stuff that we're not particularly interested in doing. If people are interested in it and they take the first step, they'll probably engage and they'll probably keep going. And actually, by the time they're going out a few times a week, they've forgotten to take their lunchtime dose of gabapentin because they were out and about.
I'm just thinking about like a surgery consultation. So someone might come and see me. They might have had ongoing back pain for quite a number of years, and they've been prescribed some gabapentin and some codeine, and they're using that fairly regularly and they're ordering it regularly. How do we open up, or how can a clinician open up that conversation around moving on from that situation to think about how to activate or engage the person to see that there might be benefits in doing something different? So how can that conversation start, and what might be the next steps in that sort of surgery consultation in terms of who to link in with to ensure it's all sort of joined up and it all works well for the benefit of the individual?
I think it's all about shared decision making, isn't it? What I tend to do is, my first question isn't tell me what medication you're on. My first question is tell me what it's like to live a life with chronic pain, or tell me what it's like, give me a day in the life of whoever it is. And that hopefully then makes that patient realise that I'm not there just to take their medication away. I want to help them with their chronic pain. I want to help them live well with that chronic pain. It engulfs your whole life, doesn't it? So that's what I would say, is finding out about that person's pain and what is it that's important. And that's what Lydia was saying as well. You've got this circle of activities that you feel you can do, and they might be very, very small. What our goal is to try and make that circle a little bit bigger so that the activities that you really want to do. So I'm not talking about they want to run a marathon. I'm talking about they want to be able to lift the grandchild or something like that. It's focusing on that. But again, if you've only got 10, 15 minutes to chat to this person, it can be very difficult to do that. So I would say send a task to your pharmacist. And that's what we do in
So something about maybe
Street.
planting the seed in the consultation and then an onward referral to a member of the wider primary healthcare team to have a bit more time to unpick and explore and see what's important, what for that individual, what actions they might choose to work towards.
That's the best type of task that I could be sent, is that the GP's already had a conversation with that person and, sown that seed, and it's given them time to have a little think about it, and then I will help them through that.
And is that a fairly standard offer across surgeries in North Cumbria in terms of chronic pain management support, looking at that holistic approach and that sort of de-prescribing or safer prescribing in chronic pain?
Yes. So I feel that your practice pharmacist is best placed to have that time to help the patient change their mindset. And it takes a long time. And as I said before, it's a dance, and GPs don't have the time to do that. And I think that's really useful that myself and Lydia and Carrie Ann now in Spencer Street, the physio, we work closely together. And there usually isn't a GP involved, only if it gets difficult. If we're needing a little bit more help, then yes, I would refer on to one of the GPs. But a lot of the time we can manage these patients within our little group.
And we can discuss those patients during our mentoring periods as well, can't we? So we can have those discussions with our sort of mentoring clinicians to say, this is the situation, this is what we're doing. And it's usually crack on, let us know if you need anything. And I think that's a really good way to be able to work with the GPs in the practice.
And we often hear about siloed working, don't we, or not joined up thinking in the NHS, but what you've described is a really good example of working collaboratively around the needs of the patient through a particular treatment journey, as well as being a point of contact for the patient, recognising how challenging it is to meet the needs of patient care through a more traditional sort of GP access model. So once that initial conversation's happened, there's a team approach, there's a point of contact and a very, very much holistic care and support planning sort of journey through that.
Yeah, it's working together, isn't it? I think as a team we work
And
really
we want
well
to
together.
try to prevent things before they get to a crisis point. If you can catch something, if there's a niggle as a GP, if you're listening to someone, you think something doesn't quite add up. This patient said, I'm all right, and this is happening and that's happening. Sometimes it's the question of, have you got everything you need at home at the moment? I often say to people, what are you having for tea tonight? Because actually a lot of people then turn around and say, I haven't got anything in, but on Tuesday I'll have some money to be able to get something. So it's just that sort of remembering to make that routine inquiry about those other social factors.
And knowing where to signpost people too. A GP's often historically been defined as that cradle-to-grave practitioner who's also the confidant, the priest, the social worker, the friend, the support, sometimes the odd job person when needed. But because of pressures on the system, that holistic approach of general practice has taken a bit of a sideline. So knowing where to be able to signpost people to for support, utilising third sector VCSE and knowing what's available in someone's patch in a neighbourhood is really important. I guess that's where your skills in particular, Lydia, come in, just knowing the lie of the land and knowing how best to signpost and support people with the more than medicine or non-medical needs.
Social prescribers have the time to have these discussions with patients. There could be something that a GP will refer and say, I think it will just be a quick one. And you could be on the phone for an hour and a half because the floodgates have opened then and everything comes out. So I think if you've got any queries or any concerns, if you are a GP, just like Katie says, task or speak to your social prescriber, your pharmacist, your care coordinator, whoever you've got going out in your surgery and doing that holistic care, send them out, have that conversation with them. because we can see patients. We're really lucky. We've got time. I can see patients at home, in the community, in the practice, over the phone, on a video call, whatever they want. I've got patients that I just email. They can only cope with email at the moment, and that's fine for whatever reason. We've got the time to really support accessibility needs as well. And I think if you meet somebody where they're at and you've got the time to do that, then automatically you're more likely to see good engagement from them.
And we've been out and done home visits together, haven't we?
We do, yeah. The two-pronged attack. Mm-hmm. Everyone's worst nightmare when we turn up.
Could I ask a question? I got a letter from a consultant colleague last week who was discharging a patient from, I think it was a neurosurgical opinion, and there was nothing further neurosurgery could offer for that patient. And a sort of final sentence on the letter said, please refer to local back pain clinic. And I'd just be interested to hear your views on what that means in context and how I might respond to that specialist request in North Cumbria to support the patient with their next steps.
So what I'm now thinking is that I would want to speak to that patient and just talk to them about their pain and find out what it is they actually want, rather than thinking, what do I do? Do I refer them to PPSS, or what does that actually mean, the lower back pain clinic? Mm-hmm. What I would do in your shoes is send a task to your pharmacist and ask them to have a chat to them, or your social prescriber, because that'd be something you could talk to them about too.
And I think we're all at risk sometimes of using or having our time wasted by people requesting from various areas, requesting information or requesting onward referrals. And if we spend so much time looking at what is available and we spend 20 minutes looking into what's available locally, but we haven't actually asked the patient first, chances are you'll then phone them, say, oh yes, I found this that should suit you. And they'll say, oh, first I've heard of it. It's not something that I think I need at all. And then you think, oh, I did. So I'd say finding somebody who's able to speak to the patient first is key.
Yeah, because there's a risk of it all being very transactional without the patient being involved.
Yes.
So in that situation, so I get the letter through, rather than me thinking, right, forward that to pain clinic, whatever that is. So a conversation with the patient, and in terms of resourcing, if our clinical pharmacist is able to have that conversation to unpick it, try and understand the patient's expectation and what they might have been told already, or what they might have done already, or what they're looking for, to open up that conversation would be sensible, rather than just a referral into a system that might not meet the patient's needs or might not meet the patient's wants.
Sometimes patients would get a letter, if you had done that referral immediately, they get a letter 4 weeks later in the post and think, oh, I don't even know what that's related to, because actually they've quickly skimmed through their discharge letter, or from whichever service it was that they were initially with, quickly skimmed through it, never thought about it again. Then 4 weeks later, 5 weeks later, something turns up, oh, you've got an appointment here at this place, and with no context for them. So they turn up to yet another secondary care service, and they're not sure why they're there. And I think a lot of the time you phone a patient and speak to them, they say, oh, I don't really know why I'm here actually.
A number of years ago, the National Voices sort of umbrella third sector organisation did a number of personalised care statements, and one of them was no decision about me without me. And that is just so important to put into practice, particularly in a world where the pressure's on, and it's often easier to be transactional in our care rather than person-centred or relational. And it's the relational, from hearing what you've said this morning, it's the relational that makes a difference rather than the transactional aspect of issuing the prescription or making the referral. It has to involve and has to be about and around the person rather than about the system.
And if we fire off a referral and complete that task, and that's tick one done for us, it looks fantastic for the data of how much work we're processing. But there is a person at the end of that who that might not have been the right decision for. So yeah, absolutely.
If you look at all the information first and then you speak to the patient, actually they may not want to go to ICANN, or they may not want to do anything else. When I was doing structured medication reviews, I used to spend 20 minutes looking at what the patient was taking, looking at all their notes and writing little notes down, and then I would speak to the patient, and actually what I was reading was something completely different to what the patient was wanting to talk about. So now what I do is, if I'm doing a structured medication review or I'm phoning somebody for the first time because they've got chronic pain, I'll look at the basics. I'll want to know if they're hard of hearing or if there's a learning disability there or anything like that. So I'll be ready for the conversation. But I want to know from their point of view what their health is like, not from the notes. So similar to what Lydia was saying, you just go in there and you speak to the patient and find out what their life is like.
So something about being informed but not making assumptions.
Yes.
And not being afraid to speak to the person to understand what's going on.
And that does take a little bit of experience to know that it's going to be okay if you haven't done all of the work. You know, you haven't looked at all the different interactions of the medication or...
And you've bought yourself time, really, haven't you, by doing that? You've bought yourself the 10, 20 minutes you would have spent clawing through the notes to actually speak to them. And by then you may well have sort of come up with an idea together. I always say to patients, well, come up with a plan together and then I can always give you a call next week and we can change the plan. It's fine. It doesn't matter. It doesn't matter at all.
So I want to talk a little bit about changing the mindset of the patient, because that's a massive thing in chronic pain. So if they're on a lot of opioids, then you can get this adverse effect called hyperalgesia. What I try to do is try to explain to the patient about it, and I liken it to a car alarm. If you imagine the car alarm is going off and that's your acute pain, to stop that acute pain you give an opioid, say, and that's fine for a while. And then after, over a few months, you start to get this adverse effect called hyperalgesia. So if you then imagine just a little butterfly landing on the car and that makes the car alarm go off. So I explained to the patient that your nerve endings can become so sensitive that you begin to get, and patients mention about all over pain, your pain threshold is a lot less than what it would normally be. So it's trying to explain to the patient and help them understand what we are trying to do. We're not just taking away the medication because it's not a cost thing. It really is to help them be more functional in their day-to-day life without this medication.
It's important to mention as well for patients that everybody in the world lives with some element of pain. Everyone has some pain. So the goal is never, to be free of pain. The goal is to not have these individual issues with chronic pain where you feel as though everything hurts all the time. It's okay to have some pain, because actually pain's what's telling us that things might not be wrong, and we need to be able to catch those signals in between other pain.
This question is generally asked to all the guests in the different episodes in slightly different ways, but if there was one thing that you could change that would make a difference to what you do, what would it be?
If a patient comes for an appointment, and we're using chronic pain as the example, they can come in and they can see, so if they want to see a GP, they can see a GP, a pharmacist and a physio and a social prescriber. Just holistic appointment that you can almost, it's not a quick fix, but you can see everybody that you need to see to try to help with the chronic pain. So in an ideal world, it'd be great to have a one-stop shop.
So something about very much personalising the offer to the individual with different professional skill supports available.
And we have thought about trying to set that up in Spencer Street and having a chronic pain, say, afternoon cafe, something like that, and trying to do that, but it hasn't.
Not there yet.
No. It's the time, isn't it?
And the space.
So Lydia, same question to you.
I would change the initial conversation that we have with a patient, whoever has that conversation, and really set the expectation that we might not find a diagnosis that solves the problem. Having a diagnosis and being told you have a condition doesn't solve the way you feel every day in your body if you're living with pain or anxiety, whatever it is. Let's not focus on seeking a diagnosis and a name for something. Let's focus on seeking a way to live functionally with how you are and how you live in your body.
So something about changing the narrative.
Absolutely.
Yeah. I think that's us for this morning. Our time is up. So Katie, Lydia, Paul, thank you very much.
Thank you.
Thank you.
Thank you for having us. What a treat.